everyone, and I extend a very warm welcome to each and every one of you who's taken out the time to join us for this webinar on Descemet stripping automated endothelial keratoplasty. I am Dr. Neha Kapur. I'm a senior consultant in cornea and refractive surgery at Dr. Shroff Charity Eye Hospital, Delhi, India. And before we begin, I'd like to thank CyberSight for doing these great academic sessions, which are very valuable indeed. So let's proceed. So we know that endothelial keratoplasty was started in 1956 by Tillet. And since then, there have been so many modifications and it's come a long way until 2006 when Borovoy introduced the use of a microkeratome and brought about the concept of automated endothelial keratoplasty. And from there on, we've only seen it evolving very beautifully into a very nice and a very good surgery where we can actually promise great visual results to patients. What is endothelial keratoplasty? So we're basically talking about a posterior lamellar keratoplasty, which can be divided into a DSAEK, where there is descent, endothelium, and some part of posterior stroma that is involved. And the next refinement of the same technique has now become DMEK, which is Descemet membrane endothelial keratoplasty, which is an even finer, about 15-20 micron thick tissue. We will today be concentrating on DSAEK. So before we begin, we'll be just taking a quick overview of what everyone thinks on this scenario, where you have a 49-year-old female with decreased vision in the left eye for 5 months, with a history of TRAP done 9 months back. This is the clinical picture of the patient, where in the left eye, you do see corneal decompensation, typically centrally and inferiorly, with an area of broad-based PAS and iris atrophic patches and ectropia on UVA. The fundus being hazily visible and the IOP of 13 millimeter HG. This is the specular image of the same patient. And if you were to diagnose and plan the management for this patient, what would be your choice of management and what would be the diagnosis in this case? Would you do is it Fuchs or is it an ice syndrome? And if it is Fuchs, would you like to do a cataract surgery with a DSAEK? Only a cataract surgery because the visual axis is clear? Or do you think it's an ice syndrome, where you'd want to do a cataract surgery with a DSAEK, a cataract surgery alone, or cataract surgery with a penetrating keratoplasty? Okay, so we have multiple opinions here. So the diagnosis is an ice syndrome and not a Fuchs endothelial corneal dystrophy. You don't see such broad PAS and ectropion in a Fuchs dystrophy. This is basically an ICE syndrome. Also, the management here will technically involve a DSAEK, because here you would like to do stretch pupilloplasty or using iris hooks to dilate the pupil. We do a synecholysis and club it with a DSAEK. We'll be learning more about the procedure as we go along. So DSAEK has significant advantages over a full thickness keratoplasty, including better tectonic stability, no corneal graft sutures, faster visual recovery, less risk of sight-threatening complications, and less risk of immune rejection, because the lesser tissue you transplant, the lesser is your risk of rejection. Worldwide, there are significant trends of change in the patterns of keratoplasty. And if you see, the incidence of endothelial keratoplasty has actually gone from 0.4% to 30%. And if you look at the developed world scenario, you see that EK tends to be the most commonly performed procedure amongst the keratoplasties, whereas developing world like India, penetrating keratoplasty still continues to be the most common procedure done amongst the keratoplasties. And this is our work that we had recently published, where if you look at the gray icons, you can see these gray bars represent endothelial keratoplasty, showing that our numbers of EK are also increasing over time now, but penetrating keratoplasty still continues to dominate because the common indications that we have in our scenario are usually corneal scars or corneal ulcers. Now let's look at the indications of endothelial keratoplasty. The most common being post-cataract surgery edema, which can be in the form of an aphakic bullous keratopathy or a pseudophakic bullous keratopathy. We commonly see Fuchs endothelial corneal dystrophy, where you can see these typical guttae and the specular microscopy like this. Other endothelial dystrophies like a CHED or a PPMD are also common indications of a DSAEK. Failed graft also becomes an important indication today of DSAEK, ice syndrome. And the other indications would include endothelial decompensation, which could be secondary to a VR surgery, trauma, post-glaucoma surgery, post-recurrent herpetic endothelitis. And the contraindications to doing a DSAEK would include deep stromal scarring or opacity and high or irregular corneal astigmatism. Now, once you have decided based on the indication that DSAEK is the surgery you're going to perform, what is the preoperative evaluation that should be done? So a thorough history taken, which checks the onset and duration and progression of the symptoms. It's important to know that sometimes post-cataract surgery, a patient may have edema, which may not resolve for about 3 to 4 weeks. That would not be an appropriate time to do an endothelial keratoplasty. We have to give time to the endothelium to come along. Also, sometimes there may be associated pathology like a Descemet detachment, which may be correctable by just a small procedure like a descemetopexy. Sometimes there is edema, which may require just a trial of steroids. So about 6 to 8 weeks post-cataract surgery should be the minimum wait period before you decide that the patient needs an endothelial keratoplasty, unless you can certainly tell that there is no DM in the eye at all, and so there is no scope of improvement. The examination would include vision and intraocular pressure. Intraocular pressure is important to know because you should have absolutely controlled intraocular pressure during the surgery for any keratoplasty. Likewise, for a DSEK, it is important because people who have advanced glaucomatous cupping, a complete airfill may lead to a complete shutdown of the optic nerve, and so we don't want that. Also, to control the intraocular pressure, you can use glaucoma filtering surgeries or other procedures and then plan the endothelial keratoplasty. What is the extent of corneal edema and stromal scarring in the eye? What is the AC depth if there's any active inflammation in the eye? What is the pupil and iris configuration if there's any PAS? What is the status of the lens and the retina? Now, when we talk about the lens status, it is important to know whether we're dealing with a phakic, pseudophakic, or an aphakic patient. Ideally, if there's cataract present, air bubble will also lead to formation of a cataract, which you will be leaving post a DSAEK. And so it may be ideal to do a triple procedure where you'll be combining an endothelial keratoplasty with a cataract surgery. If you're dealing with a pseudophakic patient, it's important to know what is the type of lens in the eye. What is the centration and location of the lens? Is it in the sulcus? Is it in the bag? Or are we dealing with an anterior chamber intraocular lens? Where are the haptics located? Because when you put the lenticule in the eye, there needs to be significant gap between the intraocular lens and the lenticule that you're putting in. What is the status of the posterior capsule? If there's any vitreous in the AC, it will not allow your lenticule to unfold. And so it is important to know that your AC is clear of any vitreous. What is the anterior chamber depth? And if there are any associated synechia, they will have to be addressed as well. In an aphakic patient, what is the posterior capsule status? What are the iris abnormalities present? What kind of lens would you want to pick? Also, when you're dealing with a patient where an IOL exchange may be required, because if you have an unstable IOL, it's always better to first take out the lens, put in a stable intraocular lens, ensure that a nice bubble can be maintained in the eye, and then proceed with the DSEK. What are the investigations that you need in these patients? An ASOCT, a specular microscopy for diagnosing the patient, and a B-scan for the posterior segment status. How does the ASOCT add value when on the slit lamp, we can already almost gauge the thickness of the cornea and also the level of scarring? So ASOCT will ascertain the exact thickness of the cornea, the details of stromal scarring, because like we read earlier, stromal scarring is a contraindication to doing an endothelial keratoplasty. Probable cause of an endothelial dysfunction, is it a DMD or something else? What is the posterior bone profile in cases of a failed graft? If there is severe corneal edema, which precludes a good view, if there's presence of synechia, what is the IOL position? All of that can be ascertained with an ASOCT, and also the AC depth. For example, if you were to just look at this clinical picture, one may think that this is significant corneal scarring and may not keep DSAEK as a possible option for this patient who has an intraocular lens in place, has a fairly round pupil with a little tethering of iris. But when you look at the ASOCT, you see that there is such a significant amount of epithelial hypertrophy, which is not scarring. This can just be peeled off with a bud or a simple 15-number blade, and you see that there's no underlying stromal scarring, and this patient is actually a great candidate for an endothelial keratoplasty. What is the importance of how thick the host cornea is? It'll help you in the surgical planning because a very thick cornea may not always clear very well with a Descemet stripping automated endothelial keratoplasty. So usually corneas up to about 800 microns clear well with a DSAEK. About 800 to 1000 microns may have a slightly longer course of recovery. The corneal edema may take a little longer to recover. The graft adherence may be a little more challenging. And also the complications that you can have with increased corneal edema, and poorer view has obviously to be emphasized as well. Usually more than 1,000 microns, we prefer to do a penetrating keratoplasty instead of a DSAEK. Now, what is the ideal tissue that we would like to use for a DSAEK? A death to preservation time under 20 hours if the donor body is refrigerated, or less than 10 hours if it is not refrigerated. The central endothelial cell density of more than 2,300 cells per millimeter square. No more than mild polymorphism and pleomorphism, absence of guttae, and no evidence of central EC damage, trauma, or dystrophy. It's important to have a good rim in the tissue of about 2 to 3 mm. And as we see how we prepare these tissues, we will understand why this is important. And it's preferable to have phakic tissues so that you don't have prior incisions where your DM may be tightly stuck and tissue adhesion, tissue preparation may be more challenging, and non-diabetic eyes. We'll proceed to the surgical steps and we'll be discussing them under these 3 heads: donor preparation, recipient preparation, and donor lenticule insertion. The donor preparation can be done by a manual method, or it can be done with an automated method. We'll first see the manual preparation of the DSAEK tissue. So on an artificial anterior chamber, we will put some visco and then we put the fluid, which usually can be the cortisol or the tissue medium in which the tissue is stored. If you see, the tissue now is kept with a good rim of 2 to 3 millimeter. And this is important because the tissue has to be locked in with this only when there is a good seal that your tissue will build up adequate pressure and you can get a good cut. Check the pressure. We use a guarded blade to create the first section. After this incision, we take a crescent knife, and with the crescent knife, we make the initial entry into the cornea. After the initial entry into the cornea, we take lamellar dissectors, which are straight up till mid half of the cornea. And then there are curved dissectors to curve over the half of the cornea and go across up till the opposite limbus and all across to free the entire tissue. After this plane is created, it's important to maintain adequate pressure, release the seal, and snip the tissue. And then it is placed on the Teflon block. And with a suction trephine, the tissue is dissected, marked, and then it is ready for insertion. We usually now, most places have automated modality of preparation of this tissue. And here we will demonstrate this. You can have various microkeratomes to do this. We use a nitro microkeratome, no financial interest, but the most commonly used is the Moria microkeratome for doing this dissection. This tissue preparation has to be done under a lamellar hood in a clean room. The tissue is mounted similarly on an artificial anterior chamber. Maintain adequate pressure on the machine. The tissue is locked in with a cornea fixation cap and then the screw ring to lock it in position. After this threaded ring is placed in place, we check the fixation, the instruments, the pressure in place, check the eye pressure because this has to be taut. We do a corneal thickness measurement, mark for a reference, and then you have to wet the hinges where the blade is going to run and the head of the microkeratome to allow an absolute smooth and an obstruction-free passage. The microkeratome blade that is usually used is about a 350 micron, and the nomogram that we usually follow is that if the corneal thickness is about 570 micron and under, we use a 300 micron blade. And if it is more than 570 microns, we usually use a 350 micron head. The cap is dried, the bed is dried, and the tissue is placed back in place. It's very important after this step, when you release the tissue, that adequate fluid is pushed to release the tissue because at no time you want the tissue to collapse because collapse of tissue will cause endothelial cell damage. The tissue is then placed in the cornea viewing chamber. Quality check of the tissue is done, which will include the endothelial evaluation, and then the tissue is ready for usage. There are many places where endothelial keratoplasty tissue may not be available for automated use. And that is why there's literature where automated tissue preparation is seemingly better than the manual tissue preparation. But there was a recent publication which showed that the outcome was similar in both groups, whether a manual tissue was used or an automated cut was used. And this can thus be used in low resource centers and countries where there is no provision of doing automated endothelial keratoplasty. Your tissue outcomes and thus the graft outcomes seem to work very well as well. Next, once our tissue is ready, We go to the recipient preparation. We ensure that the donor graft is in good condition before we start. We put a facial and a peribulbar block for the anesthesia so that the patient is immobile and comfortable. We look at the rest of the steps in view of the surgery. Before we proceed, we'll also look at what our trolley is supposed to have. So we have the regular intraocular instruments that we will use for any cataract surgery also. And in addition, we'd use some extra instruments. So routine side port blade, we'll use a keratome blade, which is a 2.8 millimeter entry. We have two syringes, important 2cc syringes. We usually prefer the BD syringes because they have a very smooth passage. It's always preferable to have separate cannula for hydro and for air. We prefer to use a screw speculum instead of a wire speculum. A caliper needs to be there on the trolley to measure. Your limbs, McPherson, the suture tying forceps, the viscoelastic that we use before we put the tissue inside is usually a cohesive viscoelastic because you want, if there's any visco that goes in, it goes in and comes out as a bolus, and you do need some to protect the endothelium. We need a dialer and a reverse Sinski, which is basically the scoring instrument that we use to do the desmetorexis and peel off the DM. The tissue insertion devices, which could be any based on personal preference, we will be using a sheets glide, a trypan blue to stain the DM. We will be needing a marker to mark the tissue, wet cell sponges, a suction trephine, 10 nylon suture, and the tissue that we will be using during the surgery. Now, a lot of times, like we saw one of the cases where the epithelium had significant hypertrophy. And as you can see in this figure also, there is significant hypertrophy of the epithelium, which obscures the view. And with just a simple bud or a 15 number blade, the epithelium can be completely taken off. And you see how nicely the view clears up for the surgeon. The next thing that is important is to mark the area where we are going to do a desmetorexis, because it is important that the tissue that we are going to put, we are going to measure. And usually we measure the horizontal white to white, and we don't go 3 millimeters. We go about 3 millimeters below the horizontal white to white and no further down. We usually try to stay in the range of 7.5 to 8.5 or 9 millimeter for the tissue that we are putting. It's always a good practice to mark the cornea from on top. You can either use a caliper with the marking ink and mark, and this is your reference for the desmetorexis, or you can use a trephine, and not to trephine, but just to make that mark so that you have a clear marking of how much you have to score. The instruments that you will be using for the desmetorexis typically would include a Descemet scorer and a Descemet scraper. A scraper is a more thicker, broader, and a blunt instrument which will pull off the DM after it is scored 360-degree and removed from the eye. So desmetorexis can be done either under viscoelastic or under saline or under air. This video is a triple procedure, and thus it was done with a viscoelastic. And it's important to note that we prefer to use a cohesive viscoelastic so that it comes out in mass and you don't have any visco sticking to the undersurface, because you want your DM to stick very well with the bare stroma. So we stroke 360-degree, free it, and then pull the DM from everywhere and get it out of the side port incision that we make. This one is done under viscoelastic. Viscoelastic we would usually use if we are combining it with a cataract surgery. The alternate modality, and usually what beginners like to use, is under fluid. And for that, we like to use an anterior chamber maintainer. And this is how you make an opening with a side port blade to have the AC maintainer in the eye. Once the AC maintainer is in the eye, there is constant fluid flowing in the eye and you don't lose chamber, which is important because sometimes with air, people struggle to maintain chamber and constant in and out makes it difficult. An AC maintainer will constantly keep the eye formed. But the other disadvantage that it has is that because of the constant flow, the DM keeps unfurling. So the DM that you have scrolled, it keeps going back and sticking to the cornea. And here trypan blue dye comes in handy because it stains it well and you can still have a clear view of the scored Descemet. What I will be using live in the surgery will be air, and that will be the third modality, which I will then be explaining as I operate. The next important thing is, where am I going to sit and make my incision on the eye? So a couple of things to be factored in here are the position of the incision, and the references here would be where were the previous incisions placed. And if there are any previous incisions that are not made well, you usually don't want to cross those previous incisions, and it's better to make your own fresh incision. Where do you have the best view from? Where do you have the best access from? And a lot of times we prefer to have temporal incisions, but there's nothing fixed that you have to have temporal. It's just that temporal gives you the best access. But if there are PAS which are temporal and you don't have enough view from temporal, it is perfectly okay to make a superior incision also. If there are PAS, we usually like to lyse them. And before we proceed, it's always good practice to put in an air bubble and see that you're maintaining good chamber before you proceed further and make the incision. Also, what is the size of incision that we make? Pretty much depends on what is the insertion of the tissue, the modality that we use. That decides the size of the incision. So there was this study done by the Price Group where they evaluated the difference between a 5 millimeter incision versus a 3.2 millimeter incision. And they said, however, the graft success was comparable between the two groups, but the cell loss that was encountered was much lesser with a 5 incision than the 3.2. And it's logical enough because your graft is not folding through a smaller incision in a 5 And so there is no compression and lesser endothelial cell damage. If your surgery of the endothelial keratoplasty is to be combined with a cataract surgery, the couple of things that have to be factored in will be what is the size of the rexes that you'd like to keep. And usually we'd like to keep about a 0.5 cover of the IOL 360-degree before we proceed with the endothelial keratoplasty so that your lens stays in the bag. The IOL material that you use, and typically we like to avoid hydrophilic IOL material because the air bubble tends to cause IOL opacification. The IOL power that we will be implanting, and usually DSAEK causes a hyperopic shift in the eye, and therefore we like to tend to go about a diopter or so myopic with our IOL power calculation. And the smetorexis, like we discussed in a phaco case, can be done under a cohesive viscoelastic. We'll take the second poll question here. If you were to encounter this 54-year-old patient with Fuchs endothelial dystrophy, you have this big bulla on the cornea and a soft white cataract with this anterior segment OCT, what is your surgical plan? Would you do a cataract surgery alone? Would you do a cataract surgery with a penetrating keratoplasty, or a cataract surgery with a DSAEK, or a cataract surgery alone and followed sequentially by a corneal transplant? I'm glad most people agree with doing a cataract surgery with a DSAEK, which is exactly the modality that should be followed. It's a nice soft cataract. Once you peel off the epithelium, you'll have a very clear view. Proceed with the phaco and then with an endothelial keratoplasty. What are the tissue insertion techniques that we have? So you can have push-in techniques or pull-through techniques. And the typical examples that we have for push-in are sheet glide, which is an absolutely economical, easily available plastic sheet that we have about 5 millimeter in the biggest diameter, or an endoserter, which is a one-time used but an expensive device. It can be clubbed with your phaco machine fluidics and injected just with your foot pedal. It's a clean entry, and it can also be left sutureless. The other technique which can be used as a pull-through technique is a Busen's glide. And Busen's glide is also a very reproducible technique where you see on the flange the tissue is placed, and from the opposite side a forceps is put in. So this is the flange of the Busen's glide docks the tissue on the eye, and the opposite forceps just pulls the tissue inside into position, and then we go ahead with the rest of the surgery. This is how we use the sheets glide in the eye. So we usually make a 5.2 millimeter incision. Have the sheets glide fit in snugly across up till the opposite angle. We don't like any air bubbles in the eye after the sheet glide is in place, because once we put in the lenticule, you don't want any confusion with where your air is going. So we like to keep the chamber formed in hydro only. Next, after we have the automated tissue available from the eye bank, or if it's a manual prep of the tissue, we keep the tissue on a suction trephine. Depending on what is the size of the tissue that you want to put, you take off, do the trephination, take off the cap, and then you go ahead and mark the tissue. So a lot of times eye banks will give you a pre-marked tissue, but a lot of times these marks can be smudgy, and this is not something that we need to compromise. Do a 360-degree separation to make sure that the tissue is fully separated. Use your dialer only to fold over the tissue, dry it with a Vexel without causing any compression with a gentle dab, and then mark the tissue with any asymmetrical letter of your choice, which will be able to tell you the orientation of the tissue once in the eye. The donor lenticule insertion, it's important to have that the orientation of the tissue is maintained very well. The incision is enlarged as per requirement, and the tissue is inserted in the eye. Once you have to insert the tissue in the eye, it's good to put this cohesive viscoelastic on the sheath glide. It should be thoroughly placed because the endothelium is going to rest on this with the limbs and a dialer. We hold the mouth of the incision, shove the tissue inside. Gently by closing the mouth of the incision, pull out the sheath glide and put the suture on the incision. Don't bother about the orientation of the tissue. Just close the incision with one single suture and then form your chamber with hydro and figure out the orientation of the tissue and then go ahead. A lot of times our tissue may not be perfectly centered. And as you can see here, the tissue is decentered inferiorly. So to center it, you put in some air, and a tissue in a DSAEK eye moves only when the chamber is stopped. So you need a filled eye to move the chamber, and you can have this manual rocking with a cannula to move the tissue in the direction where you want to move. Sometimes as a last ditch resort, if this manipulation is not helping, you can have a one-off time where this direct tissue centering can be employed. But this usually should not be the primary modality where you take in the reverse Sinski and pull the tissue in the direction where you want to keep it in position and then put in air. The air tamponade is left for 10 minutes in the eye. Usually, if you have an eye that is post-glaucoma surgery, vitrectomized eye, or absence of PC, we may need to leave a stronger or a longer fill in the eye. By the end of the surgery, after the 10-minute period, it is important to leave a mobile air bubble and have a clear meniscus of aqueous around to prevent pupillary block in the patient. The patient should lie about 30 to 40 minutes flat in the recovery after surgery. You can see the patient on the slit lamp an hour later. To ensure the graft is centered, attached, check the digital tension and if there is any pupillary block. Postoperatively, we typically, like any other procedure, usually would be giving an antibiotic, a steroid eye drop, and a lubricating eye drop. And sometimes to prevent a pupillary block, if your iris is very floppy, it's good to give a home atropine eye drop to keep the pupil dilated so that there is no pupillary block. If you look at the visual recovery, it's seen to be extremely good by the Price Group and many more publications. The endothelial cell loss typically at 1 year reaches about 32%, and then it plateaus down. And at 15 years follow-up, the Price Group has noted about 78% endothelial cell loss. If you look at the complications, you can have during the intraoperative procedure, during the tissue prep, a DM perforation or button holding of the donor, where you may need to use a new donor button. If it's a too thick or too thin donor lenticule, you may need to either re-prepare the donor or be very gentle with the handling. If there's a reverse unfolding of the graft in AC, you may have to replace the donor and inject air carefully. The donor button ejection can happen during air injection, and that's why it's important to secure it with a suture and then proceed with the rest of the tissue maneuvers. You can have an incomplete DM strip or an iris injury. So like one of our residents, while doing this DSAEK, inadvertently, while enlarging the incision for the tissue injection, happens to injure the iris, and you see there is a profuse iris bleed. It is important to not panic, and this is not a reason to abandon the surgery either. Put in a tight air fill, do the graft preparation. By the time you come back, the blood would have stopped. Early postoperative period, you can have donor dislocations, detachments, air-induced pupillary glaucoma, primary graft failure, infection, TAS, early secondary glaucoma, blood in the interface, and in the late postoperative period, again, you can have all of these complications where you can have glaucoma, interface haze, rejection, infection, CME, RD, or a cataract progression. We'll just take the last poll question. We have the 65-year-old female patient with a pseudophakic bullous keratopathy. Having this as the thickness of the cornea and this be the specular, what would be your plan of management? Would you do a DSEK, a DMEC, a DSEK with venting incisions, or a penetrating keratoplasty? Interesting. So a lot of audience wants to do DSEK, and about 41% think that they should be employing venting incisions in this case, and which is actually the right modality. So what venting incisions do are they are full thickness cuts into the cornea, which are made prior to the lenticule being inserted in the eye if you're dealing with a very thick cornea. It helps in drainage of the fluid much better, adherence of the graft much better, and thus a quicker recovery post-surgery. So we'll take some questions from the chat before we start the surgery. So which layer of cornea is replaced in DSEK? So like we discussed, we would be dealing with the DM, the endothelium, and posterior stroma. Which instrument is used for opening of the eye? If you're meant for the descemetorrhexis, we use a side port. If we want to make an opening in the sense doing a keratometry for the insertion of the tissue or the sheath slide, we use a keratome blade. Initially, we make a 2.8 mm, and for the sheath slide insertion, we make a 5.2 mm insertion. Why does DSAEK have faster visual recovery compared to PK? Because a DSAEK, unlike a PK, there are no sutures on the eye. Your risk of rejection is less. It is more physiological than a PK. So it has a much better tectonic stability and thus faster recovery. What is the benefit? The advantage of DSEK and major complications. So like we said, the benefit of DSEK versus a PK typically is no sutures, no 16 to 24 sutures like you put in a PK. You don't have those. Thus, astigmatism control is much better. There's better tectonic stability. And so all the complications that come in with PK are much lesser with a DSEK. It's not an open sky surgery. Being a closed globe surgery, it's a much safer surgery. Also, the visual rehabilitation is much better and much quicker in these patients. The most common indication for DSEK in your sitting. So we see the maximum we see is a pseudophakic or an aphakic bullous keratopathy. So typically a post-cataract surgery edema is the most common setting in our sitting. How do venting incisions help? Venting incisions basically help by creating full thickness cuts. The graft adheres better and thus it causes better drainage. The endothelial pump starts working better and the fluid has an alternate passage of draining by those full thickness 4 cuts, which are usually made in the mid periphery of the recipient cornea. And this is done prior to putting the tissue inside the eye. There is a question about need to do an iridectomy, and I would like to address that because typically in the beginning, when we started doing DSEKs, we were always doing an iridectomy in these patients. But later we realized that with DSEK, as long as you are maintaining the 80 to 90% fill after the 10-minute complete fill in the eye, it is okay to not have a PI in the eye because there's a clear fluid meniscus that you are leaving unless you're dealing with a glaucomatous or another compromised eye. If you already have an eye which is post filtering surgery, you definitely would have it already. Or if there is a filtering surgery done, there is an alternate passage of drainage. But in the routine cases, it is not required as a mandate. However, in DMEC, we prefer to have a PI as a mandate. So if we have to put DMEC over DSEC, one of the most important criteria would be the visualization intraoperative. DSEC, because the tissue is thicker, even if you don't have very good intraoperative visualization, you can manage very well. But with DMEC, you need extremely good intraoperative visualization to take care of how the tissue is unfurling. Is it the right orientation or not? DSEC you can manage very well without that also.
Hello everyone, I'm Dr. Rupali. So this is our patient. She had a complaint of decreased vision in right eye since 4 months, and she has a history of cataract surgery elsewhere 4 months back with a poor gain of vision. This is the slit lamp photo of the right eye. It shows large epithelial bullae and stromal edema along with the pseudophakic status of the eye. The vision, this is the slit lamp photo. It shows no stromal scarring and no DM detachment. The vision at this visit was 680, and a trial of topical steroids was given. On a 4-week follow-up, the visual acuity dropped down to counting fingers to 2 meters. This is the ASOCT of the same patient. We can see the epithelial bullae. There is no stromal scarring, and the thickness of the cornea is 850 microns. This is the specular microscopy of the patient. We can see that there is no documentation in the right eye, and the left eye endothelial cell count is fine. That is 2,465. So we made a diagnosis of right eye pseudophakic bullous keratopathy and left eye pseudophakia, and planned a right eye DSEK under local anesthesia. This is the tissue details that we'll be using. The dead to preservation time was 11 hours. The cell count is 3,155 per millimeter square. This is the post-cut report. The pre-cut count was as before I mentioned 3,155, and the post-cut cell count was 3,040. So let's prep for DSAEK.
Okay, so we'll start now. So we start off first by measuring the corneal diameter. And like we said, it's important to see the horizontal white to white diameter. And this being 11, we usually would want to, like I said, not go a lot lower than about 3 to 3.5. So we'll check what a 7.5 looks like on the eye. And it looks very reasonable on the eye. So this is 7.5. So we're going to mark the eye at 7.5 to center our Descemet. Then we go ahead and make a side port incision. So we use a 1 to 1.2 mm side port blade, but we don't make a full entry. Just about half thickness is adequate. And like we've earlier shown you Descemet or T-blue. Scoring under viscoelastic and the anterior chamber maintainer with fluid. I'm going to now show you under air how we do it, so that way we cover all three modalities. So we put a little trypan blue in the eye. That'll help in delineating the Descemet very clearly in the eye. Wash off the trypan blue. And put in air. And if you can see, this is what a Descemet scorer looks like. And we have the mark where we would like to place the tissue. So stabilize with the limbs. We go in and score the DM just outside of this mark. And then start bringing in the tissue 360 degree. And this is what we were earlier talking about, that sometimes you will have frequent issues with the air coming out and collapse of chamber, but it's okay to keep forming it back. You can see the DM coming out. So usually in a DSEK, it is, of course, important to get the DM out. But if you have some small tags of DM left, it's not like it's a mandate to get each and every of those tags out, unlike a DMEK. where it is mandate to get those out because your thin membrane lenticule won't stick without those coming out. But however, of course, it's best to get all of it out so that you have your lenticule sticking well in the eye. So this is a situation where an AC maintainer actually helps because this constant in and out is avoided. But as you can see, there's a little tag of DM remaining here. We would like to address that and take that out also. And that completes the Descemet air. We'll have a final check. See, there are no more tags anywhere. Probably one segment here and one segment here. The tissue is clear of Descemets now. Keratome. So once this is ready, we make a keratome entry and get our sheets glide into place. So we like to make a clear corneal entry. A lot of times people like to intersect the entry with the edge of the lenticule, and then the good thing about it is that the edge of the entry will, because the lenticule will close against the stromal hydration, will close the edge and you don't have to put sutures there. But that usually is not our primary intention. The primary intention is to have a well-centered, adequate size lenticule. Even a very long entry may cause trouble. So we made an entry after the 2.8 with a 5.2 mm blade. We'll put in the sheets glide air. We'll put in the sheets glide in position. McPherson. There's a little DM here at the edge, which was visible. It's good to get that out if it's coming in the area of where you are to transplant the tissue, where your lenticule will sit. And now we are clean. Just pick the sheets glide. And place it in the eye, reaching the opposite angle. Get all the air out from the eye. Because like we said, we don't want any air in the eye. It's important to know once you put the lenticule in, which plane our bubble is in. So we don't want any air inside the eye. So it's always best to have the eye maintained in hydro and not air. We'll go and dissect the lenticule now. So I'm shifting the view to the lenticule dissection. So like we decided on a 7.5 mm lenticule, we will now dissect the lenticule. And this ideally should be done under the microscope only. We have a pre-cut tissue ready here. And this is the suction trephine tubing that comes in. And we have to keep it fully pressed before we put the tissue on the trephine, on the Teflon base. Press. It's fully pressed because right now the suction is not built. It's important for us to center the tissue first. And only after we are centered, we tell the assistant to let go of the suction and build it. Okay. So now the tissue is well centered. You see there is a little smudgy mark, and it's usually good to have your own mark on this. Ensure the size that you have to use is the same as what you have decided. Do a trephination. And then we pick it back up. Get the periphery of the tissue out. Dialer. With the dialer, we have to make sure that the tissue is 360 degrees separated. This is in the interface to ensure a 360-degree cut. And once you ensure a 360-degree cut, we fold the tissue on one side so that we can put a clear mark for delineation inside the eye. So we go in the interface and just go ahead and fold the tissue. We then take a Miracell sponge, dry out on the stroma. The lenticule, the endothelium is here on top, if that's not the part we are touching. Do gentle dab here on the lenticule because we want a dry bed for the mark. So from the periphery, as much as possible, dry out whatever can be taken out so that you get a good, reliable mark. This is a step which I feel is mandatory and should never be compromised. It's good to not take the ink pen directly on the eye. Instead, what we prefer to do is that we take a dialer, and with the limb of the dialer, you put it in ink. And there still is some fluid there because the mark is not taking up. So dry it before. So have a clear mark which shows the orientation of the tissue in the eye. And once this is done, we hold from the stromal side of the tissue and fold it back. Now our tissue is ready. It is marked. We keep it safe and go back on the eye. At this time, again, it's imperative to note that there should be no bubble inside the eye. Cornea wash. Retina. So there is a little DM tag which is visible here. Ideally, it's good to get it out. However, it is a very friable small tag. Even if we were to let go, it would be fine. But if you're seeing it, you may as well get it out. You can take a microforceps and get it out. It's too far for the McPherson to reach. Limbs. Going across. Hold and peel. Hydro. Okay. The next step is that we have a cohesive viscoelastic that is placed, and put this in abundance on the sheet slice because you don't want your endothelium to directly rest on the plastic. So have abundant tissue placed, abundant cohesive placed here, dialer. The instruments that you take in your hand now before placing the tissue would be limbs to hold the tissue and a dialer to push in the tissue on the sheet's glide. Some people like to use a 30 gauge needle also to do that. I usually don't use a 30 gauge needle because it is very sharp and can cause injury to the tissue. So if there's any bit of cap that you can hold, it's ideal to hold from the cap. Place the tissue in such a way that you have the endothelium resting down. Find a plane of insertion in the interface. And peel off the cap. Open the mouth of the incision with the limbs. About 1 millimeter into the tissue, you go and engage your dialer and pass it into the eye. Make the dialer horizontal and come out. Whatever be the tissue orientation in the eye, don't bother, just get the sheets glide out. Take a tissue, take a suture, and close the incision first thing. Wash. We at no point like blood inside the eye during the surgery. It will make view difficult and inhibition of adherence of the graft. Just one suture to close the incision so that your tissue is secure in the eye. As we can see, there's a little fold in the tissue, but that's immaterial. We will unfurl it now once we put hydro in the eye. Hydro. So we put in some fluid, and as the chamber forms, you see that the tissue opens beautifully inside the eye. If you can see the letter F, we can see very well, which shows that the tissue is in the right orientation. And thus, that is very important to have. The next step is you put an air bubble inside the eye. But the air bubble, the plane is important. And the air bubble has to be put under the lenticule. Hydro. So some of the bubbles have gone in the interface, and it's important to recognize this. These bubbles can just be squeegeed out of the interface. Or you can aspirate them and get them out. Air, hydro. Air ready. Form the chamber with fluid first. And this is where you want the air, under the lenticule. But like I said, we need the chamber to be tight for the lenticule to move. So like we saw, the lenticule is not centered. So we stroke it. Limbs. We stroke and we get the lenticule back in place to where we've marked. You can see the lenticule is moving freely. It's almost come to the center, just a little short. It's good to be patient. It will come in place. And now it is exactly where we want it to be. But the eye is not tight enough. We want air filled tighter. There, air. So just from the side port, we go in, reach the bubble, and grow the bubble. And it's preferable to have one full bubble rather than small bubbles. And if you all can see, this is the edge of the lenticule, and just outside of it, you can see this other ring. This is what is called the double ring sign. And this shows that your lenticule is stuck well. But the eye is still not as tight as I'd like it to be. There's a little bit of iris adhesion here in the periphery, but it's okay. All of that can be released. First, we should have the lenticule stick in place. That is important. Bud. We see the double ring sign. We see the eye. It's looking good. The lenticule is exactly where we'd like it to be. We'll put 2 more sutures, one on either side of the central suture. Allow 10 minutes of rest time for the lenticule to stick. While we are waiting, if there are any questions, I can answer the questions. Rupali, can you read if there are any questions on the chat? Time. Rupali, can you read the question for me?
Which microkeratome head or blade holder is used?
So microkeratome, usually we use here called the nitro microkeratome. But what is most commonly used is the Moria microkeratome. And the head that we use depends on the tissue thickness. If you're dealing with a tissue about 570 microns and thinner, we use a 300 microns head. And if you're dealing with more than 570 microns, we use a 350 micron head.
The next question is, how does the surgical management differ in aphakic, vitrectomized, or tube shunt eyes undergoing DSAEK?
So a phakic, we would like to put as a first choice a lens. In the vitrectomized and tube shunt, like we've emphasized earlier, the trouble there is of getting a firm or a taut eye. That is the main challenge. Other than that, there is nothing very different in doing the procedure, but we leave a longer fill there. Nothing very different other than that.
One attendee is asking, is this under general anesthesia?
No, the patient is under local anesthesia. This patient is not under general anesthesia. It's a short procedure, much safer than a penetrating keratoplasty. And so we don't feel the need of putting the patient through general anesthesia for this procedure.
The next question is there any chance of corneal ulcers with prolonged eye exposures?
if the person who's asking can clarify a little more on what that is.
The next question is, isn't blood in the eye causing any other problem?
Technically blood has fibrin, so it'll even allow the graft to stick. But fibrin can also have other issues of not allowing the graft to stick, the graft sticking towards the fibrin. So it can cause endothelial cell loss also. So as much as possible, blood should be avoided in the eye. We have a very tight globe now. We'll have a 5-minute air fill, and then we'll decompress the eye. So we have a nice double ring sign, the tissue well in place as we marked, the F absolutely straight, and the I firm, the AC very well formed. So right now we're very happy with how the eye looks.
The next question is, when are the sutures removed?
So usually after about 6 weeks, we can take off these sutures.
Is the glide always necessary?
Well, you do need something to put the tissue inside the eye with. So like we discussed other maneuvers, you could either use a Sheets glide, or you could use the Busen's glide, or you could use any of the other tissue inserters like an Endoserter, TANS and Endoglide. There are quite a few available.
What are your post-operative regimen post-DSAEK patient?
So usually we give an antibiotic for about the first week. And a lot of times we take out the epithelium if the view is not very good. Here the view is reasonably okay. But also this is sometimes loose epithelium and probably better to take out rather than leave it on the eye. And in about 3 to 6 days, the epithelium would usually grow back. So we give them an antibiotic until the epithelium has completely grown back on the surface. We give them topical Predfort eye drop 2 hourly for the first week. After that, we reduce it and make it 4 times a day, and we keep that on for about first 3 months. And then we reduce it further and make it 2 times a day, and then we continue that for the patient. If you're suspecting pupillary block, it's good to give homide to the patient, hometropine eye drop, and a lubricating eye drop for surface stabilization and healing of the epithelium. So the epithelium was looking a little loose. So we're just taking out the epithelium. Yes, okay.
What is the important follow-up protocol, including follow-up days and tests done?
So we definitely see the endothelial keratoplasty patients at day 1 and next at day 3, because usually by day 3, the air bubble is gone. And that's a good time, because sometimes even if you have a reverse orientation sticking of the graft, your graft may appear stuck, but it's actually the bubble keeping it in place. So at day 3, it's good to see the patient one more time to ensure that the graft is still in place in the right orientation, the pressure is fine. So we like to see the patient at day 1, day 3, a week later, and if all is well, a month later. But if the cornea is not clearing, we like to see them sooner.
Next question is, what are the signs of DSAEK graft rejection?
So you can see typically endothelial rejection in these patients. So you will start seeing some pigment or capes on the endothelium. The patient may come with stromal edema or a drop in vision. And looking for that endothelial rejection line becomes important in these patients. With usually the rejection is very low in endothelial keratoplasty in comparison to penetrating keratoplasty. I think the eye is fairly tight and the lenticule is fairly well stuck. Just in the end, we'll just reduce the air bubble a little to have a little clear meniscus. And it's good to not take out air, but replace some of it with fluid. And now there is a clear meniscus that we have. The eye is not very tight. Antibiotic. We like to patch the eye and keep the patient in post-op recovery for about 30 minutes. See the patient on the slit lamp once. Is a BCL used? So BCL is usually a personal preference. If we as protocol don't use a BCL on the eye, unless the patient is extremely symptomatic, then maybe next day we can use the BCL on the eye. But our first choice is not to use a BCL because steroids and BCL make a bad combination. So we are not proponents of using BCL post-procedure. Can this patient experience improved refractive error? Well, definitely the patient should do well because I'm assuming the cataract surgeon would have put the IOL with respect to a virgin cornea. The only thing is that now we do expect, because of the hyperopia, there may be a small hyperopic refractive error that the patient develops post-op, but that we will take about 6 weeks to completely define. Can we use non-expansile gas rather than air? So in patients with TRAB, we usually, as a first choice, don't do that. And giving them a longer airfill helps significantly. Non-expansile gas, however, does have a role. Sometimes when we rebubble the patient, when you have a graft detachment, and we rebubble the patient, a lot of times the first time that we rebubble the patient, knowing that there is no other abnormality, we still use air. But if there's repeat chance of a rebubbling, we do like to use non-expansile gas, typically C3F8 in these patients. But again, ensuring that it is non-expansile or isoexpansile actually that we are using, and leaving the clear airfill becomes important. But as a primary procedure in TRAP, we don't feel it is required. Do you do ASOCT routinely to confirm graft attachment? No. If we can clinically tell that the graft is attached, you do not need an ASOCT. So it is not essential to be dependent on an ASOCT. Usually a slit lamp will tell you very well whether the graft is attached or not. Is there any conjunctival complications? As here, bleeding occurred during the procedure. This is usually a very small amount. This is almost negligible. So no complication. How does the post-op IOP spike occur in DSAEK and what is the management protocol? So usually it's the first day, actually day 0 is when you do expect trouble with pressure. And we don't really feel the need for mannitol to be given in controlled eyes like these. But if you have eyes that have issues with AC being formed, eyes that are not vitrectomized, eyes where you have complicated IOLs in place and you need to do an IOL exchange, we do like to give mannitol preoperatively. And post-operatively, usually in the first 6 hours, it's important to monitor the pressure. And if needed, repeat a mannitol for the patient. Is there blood in the eye? How is it? If there is blood in the eye, how is it removed? So you can just remove it with hydro. And if it clots, if it's just a little blood, usually try to avoid allowing any blood to go in the eye in the first place. If it is there, you can just let it clot, pick it out, either wash it with hydro, or once it clots, pick it off with a McPherson and get it out. How about taco insertion? Taco insertion can also be used, but there is more endothelial cell loss with taco insertion than with the sheaths glide. And that is why we prefer to use the sheaths glide. Is it correct to pass the suture through the graft to stabilize it? Usually if you're dealing with an aphakic eye, to make sure that the graft doesn't go anywhere, yes, sure, you could do that. But otherwise, if you're dealing with a pseudophakic and you don't expect any of this trouble, it usually is not first preference to do it. Any chance of glaucoma and cataract after this procedure? The patient is already pseudophakic, so no. But if you were dealing with a phakic patient, yes, there could be. And chance of glaucoma, if you've kept a mobile bubble, then no, we don't expect trouble with the pressure. Difference in the final outcomes and different technique used to insert. Yes, there are differences in the various techniques used, but sheaths glide, Buson's glide, and endoserter are absolutely reproducible techniques. Also depends on the indication that you're using for and personal surgeon choice and preference and experience. But all of them standalone used again and again are very reproducible techniques. So if there are no more questions, we'll call it a wrap from here. Thank you very much.